Welcome, and thank you for viewing this program. This module discusses urinary incontinence following radical prostatectomy. Thousands of men each year undergo radical prostatectomy for prostate cancer. Whether it is done by open surgery or via laparoscopy with or without the assistance of robotics, this operation involves the removal of the prostate and seminal vesicles, followed by the reconnection of the bladder to the urine tube or urethra. The impact of radical prostatectomy on urinary function will vary for each individual. Pre-existing urinary symptoms may improve in some men, while in others, symptoms may remain or even worsen. In some men, new urinary symptoms or leakage, called incontinence, may develop after surgery. Incontinence means any involuntary loss of urine. There are three types of incontinence that can occur after prostate surgery. Urgency incontinence, caused by changes in how the bladder functions. Overflow incontinence, which occurs due to obstruction of bladder emptying or a very weak bladder muscle. And stress incontinence, which is caused by weakness or loss of the urinary sphincter or valve mechanisms. Urgency incontinence is urine leakage that occurs because a man has a sudden, strong urge to urinate and cannot get to the toilet in time. It is usually caused by changes in how the bladder functions, causing it to have uncontrolled contractions, like small spasms, which are associated with sudden urges. This is called an overactive bladder. It is very common and may present in many men even before prostate surgery, or it may develop as a result of surgery. Urgency incontinence may also be caused by changes in the bladder that make it less stretchy or distensible than it needs to be. Overactive bladder and urgency incontinence are discussed in detail in a separate module. Overflow incontinence, as mentioned, occurs when the bladder fills to capacity and cannot empty completely. This is typically caused by obstruction of the bladder neck from scarring. However, a weak bladder muscle may also play a role. One of the causes of obstruction following prostate surgery is scar tissue formation at the outlet or neck of the bladder. This drawing shows how scar tissue forms after the prostate has been removed, where the bladder and urethra have been sewn back together. If this scar tissue, called a bladder neck contracture, is excessive, as occurs in about 5% of cases, it can block the bladder from emptying properly. Stress incontinence occurs when the sphincter, or valve, which holds urine in the bladder has been damaged, allowing urine to leak out when downward forces are applied to the bladder, such as with coughing or straining to lift something. It is caused in part by removal of the internal sphincter mechanism, which is within the prostate and bladder neck, and also by damage to the external sphincter, which is the muscle that we can voluntarily contract to hold in urine. Furthermore, damage to nerves around the prostate may also play a role, as can damage to supportive tissues around the bladder and urethra. This drawing shows how the internal sphincter, or valve mechanism, is contained within the neck of the bladder and part of the urethra surrounded by the prostate. This valve is removed during prostatectomy, so urinary control becomes more dependent on the external sphincter, or valve. The external sphincter is the muscle that we can voluntarily contract to stop our urine flow. Because radical prostatectomy can also weaken the external sphincter function, loss of urinary control, called stress incontinence, can result. Other muscles that are associated with the external sphincter, called the pelvic floor muscles, can be strengthened by a type of physiotherapy called pelvic floor muscle therapy, or Kegel exercises. These exercises may assist in the recovery of urinary control after surgery. After prostatectomy, when the catheter first comes out, a brief period of leakage is common. Most men, however, recover good control very quickly. However, full urinary control may take up to 1 year or more. As was just pointed out, it is thought that pelvic muscle training, or Kegel exercises, may speed recovery of urinary control. Many factors determine the likelihood of incontinence after radical prostatectomy, especially age. Overall, about 5 to 20% of men will use protective pads after surgery. 15 to 20% have only a small amount of leakage, while 2 to 10% may have more significant leakage and may require surgical correction. When necessary, good treatments do exist if leakage persists. There are several risk factors cited which may determine if a man might have difficulty with urine control following prostate surgery, and all of them are debatable to some degree. These risk factors include the age of the patient, how well the patient could control his urine before the operation, previous surgery, especially transurethral resection of the prostate, or TURP, which is done for an enlarged prostate, scarring where the bladder and urethra are joined back together, the stage of the prostate cancer, surgical technique, and the training and experience of the surgeon doing the operation. Incontinence after prostate surgery is managed by a urologist, possibly the same urologist who performed your original surgery, or perhaps a different urologist with special expertise in this area. The evaluation of your situation begins with a careful medical interview or history and a physical exam. When your doctor takes your history, he or she will ask many questions to try to determine the most likely cause or type of incontinence. You will also be asked several questions about the type of surgery you had, any complications that might have occurred, the status of your cancer, your erectile function, and your general medical condition, along with any medications you might take or allergies you might have. Along with a general medical exam, your doctor may ask you to cough or bear down to try to demonstrate stress incontinence. A cystoscopy is a special test that is often performed in the evaluation of incontinence following prostatectomy. This procedure involves passing a small, flexible scope with a lens and a light to view the urethra and the bladder. The doctor will first numb the urethra or urine channel inside your penis with an anesthetic jelly, and then insert a small flexible telescope into the urethra. The images from the scope are usually displayed on a video screen, allowing the doctor to inspect the urethra, urinary sphincter muscle, and bladder neck, and to rule out any other problems inside the bladder. A urologist may also ask you to urinate into a special device called a uroflowmeter, which measures how quickly your urine is flowing. He or she may then measure the amount of urine left over in your bladder, usually with a portable ultrasound device. A slow urine flow, or large amount of urine remaining, may suggest bladder obstruction by scar tissue around the opening of the bladder. Another test commonly performed in the evaluation of incontinence is called Urodynamic Studies. These help a doctor determine the exact cause of urine leakage, to gauge the severity of it, and to rule out significant problems with bladder emptying. The complete urodynamic test is discussed in detail in a separate module. Simply put, this test involves inserting a tiny catheter, which is a long flexible tube, through the urethra and into the bladder. Water will be slowly run through the catheter into your bladder. Then, while you urinate, a computerized device will measure the flow rate and the pressure in your bladder. This procedure takes about 30 minutes to complete. The treatment of incontinence after prostate surgery depends on what type of incontinence it is. Urgency incontinence and overactive bladder are usually treated first with medications and possibly bladder training. Overflow incontinence caused by scarring at the bladder neck is treated by stretching or dilating the bladder neck or with a minor surgical procedure to cut the scar tissue. Stress incontinence may be treated with conservative measures such as exercises or with surgery. As mentioned, medications are the mainstay of treatment for urgency incontinence. One class of drugs is called anticholinergics or antimuscarinics. A newer class of drugs is called beta-3 agonists. These drugs act to relax the bladder muscle, thereby relieving frequent and urgent urination and leakage episodes. In the right setting, these medications are very effective. Possible side effects include dry mouth, dry eyes, blurred vision, constipation, drowsiness, confusion, cardiac effects, urinary tract infection, difficulty voiding, and others. These medications are discussed in more detail in a separate module. Stress incontinence is managed initially with protective pads or garments, behavioral changes such as modifying fluid intake, and exercises called pelvic floor muscle training, commonly known as Kegel exercises. These are done while waiting for recovery of natural control after prostate surgery. If, after a good amount of time has passed, there is still significant and bothersome leakage, with no sign that further improvement is likely, then further surgery to correct the incontinence may be necessary. In these cases, several good options do exist. It is important to understand that management of this condition is highly individualized and will depend mostly on how bothersome and/or severe the incontinence is. The simplest way to manage urinary incontinence initially is by using pads or diapers to protect the skin. While these can be very effective, many men are concerned about the cost, discomfort of wearing them, and possibly the odor of stale urine. External devices, such as a penile clamp, have been used by many men to manage their leakage. The device shown here, called a Cunningham clamp, is used to clamp off the urethra and prevent leakage episodes. Other types of clamps are commercially available. These have to be used with caution, as they can cause discomfort and even injury to the penis and urethra. A dedicated nurse or therapist can work with you to make some behavioral changes that can lessen the degree of urine leakage. Moderate fluid restriction is reasonable to consider, so long as you do not allow yourself to become too dehydrated. It is best to cut back on caffeinated beverages and alcohol. Quitting smoking can also help with bladder control. Timed avoiding, meaning urinating at regular intervals by the clock before you have a strong urge to go, can help to keep your bladder from getting overly full when most leakage tends to occur. Bladder training may be helpful for some patients with urge incontinence, but it is not for everyone. In this, a person retrains his bladder to hold more urine by resisting the urge to urinate for a few minutes at a time. Pelvic floor muscle exercises work to strengthen the so-called pelvic floor muscles, which support the bladder and urethra in the pelvis. These muscles are tied into the urinary sphincter or valve muscle. Through special exercises and other types of therapy, such as biofeedback, one can strengthen these muscles, increase their endurance, and gain greater control over them, which can lead to greater urinary control. These are best done under the direction of a nurse or therapist, and a separate module is available which reviews this in more detail. As mentioned, some men, perhaps 0.5% to 1%, may ultimately require surgical correction of their urinary incontinence. For these men, many treatment options do exist, as listed here, including injections, slings, and the artificial urinary sphincter, or AUS. Injection therapy, also called periurethral bulking, involves the injection of material just under the lining of the urethra in order to make the urethra close inward on itself and create a kind of seal or valve. This type of treatment is commonly used in women with incontinence, but not often performed in men. The problem in men after prostate surgery is that the area where one would want to inject the material is usually scarred, making it difficult to perform the injection and making the tissue stiffer so it does not expand very well and create a good valve effect. If one injects away from this scarred area, the material may be injected into the natural external urinary sphincter, and this may actually worsen a man's urinary control. Another problem with this type of therapy is that the body will often reabsorb or break down the material, making the effect short-lived and requiring repeat injections to get a good response. In many centers, men with mild incontinence are first offered some type of a sling, which involves placement of a material beneath the urethra to compress it, support it, or reposition it. Several different types of slings are available, and they may be placed in different ways. These are discussed in detail in a separate module. Advantages of slings include the fact that they usually do not require any adjustment, and there are no moving parts that can require any manual dexterity or that could break down with time. Surgical placement is quick and is a minor outpatient procedure for most. Disadvantages of slings include the fact that there is less long-term data available compared to the artificial urinary sphincter, and they may not work as well for more severe incontinence, or for those who have had previous radiation therapy. The artificial urinary sphincter, or AUS, has been the mainstay of treatment for male urinary stress incontinence for several decades, and remains the gold standard against which other methods are compared. Marketed by American Medical Systems, the so-called AMS 800, as shown here, is the most popular device. This device is made of 3 parts as shown: a pump, a cuff, and a balloon reservoir. The entire system is filled with fluid, usually saline. The cuff is placed around the urethra to create the new sphincter and maintain urinary control, and the pump is placed under the skin of the scrotum. When a man wants to urinate or pee, he simply squeezes the pump, and this moves fluid out of the cuff into the balloon, allowing his urine to flow. The cuff then passively fills back up over a matter of minutes, returning his urinary control. Urinary control improves in 74 to 94% of men undergoing placement of an AUS, and overall satisfaction and improvement in quality of life is reported by about 80% or more of men. Advantages of the artificial sphincter include its well-documented long track record of good results, and the fact that it can be placed through a simple minor surgical procedure with low risk. Disadvantages include the fact that the device is not activated for several weeks following surgery, and that between 16 and 46% of patients will require at least one revision of their device in their lifetime. This material is all discussed in more detail in a separate module. For a man choosing to undergo surgical correction of his incontinence, the choice of surgery will be made through a discussion between him and his doctor. Factors to take into consideration will include his age, the severity of his condition and how bothersome it is, the preference of him and his surgeon, associated factors such as scarring at the bladder neck or previous radiation therapy, and the experience of his surgeon and the resources available. The other important issue related to surgery is that of when it should be offered. To understand this, it is important to review the so-called natural history of regaining urinary control after prostatectomy. After surgery, most improvement in the urinary control occurs in the first several months, and pelvic floor exercises may speed up this process. Mild improvements then continue to occur from 6 months to a year after surgery, and very slight improvement may still occur from 1 to 2 years. With this in mind, most surgeons take a practical approach as outlined here. All patients should consider beginning pelvic floor exercises before surgery and continuing them afterwards until full urinary control is achieved. Pads are used initially to manage the situation, and in severe cases, a clamp can also be considered. For mild cases in patients who are not too bothered by their leakage, this conservative approach may be continued for 2 years or more before considering other therapy, if at all. For mild cases in patients who are more bothered by their leakage, surgery is typically considered at about a year from surgery, when most natural improvement should have happened already. Many treatment options are available for those cases, and the decision will be made in discussion between you and your doctor. In severe cases of leakage, little improvement can be expected after 6 months, so this is probably a reasonable time to consider surgical correction. Placement of an artificial urinary sphincter is the gold standard treatment in these cases. The severity of a man's incontinence can be determined in a number of ways. The amount of leakage can be stratified by the number and type of pads that he is using, or it can be objectively measured by actually counting and weighing the pads over a specified period of time, such as an hour or a day. Severity can also be gauged by measuring sphincter strength, called the leak point, on a urodynamic test. As important as these numbers, however, is the degree to which a man is bothered by his incontinence. It is an interesting fact that some men with very minor degrees of leakage are overwhelmingly bothered by it, while others with much greater leakage are not fazed by it at all. Regardless, as shown here, men with only mild incontinence, such as those using only 1 to 3 regular pads per day for protection, may choose from any of the treatment options, while those with severe leakage will likely benefit best from placement of an artificial sphincter. Some men in some centers may even be offered an artificial sphincter with 2 cuffs. This slide summarizes how the degree of leakage may affect one's treatment choice. For men undergoing surgical treatment of their incontinence, it is very important to understand what the expectations of treatment are and to discuss these with your surgeon. For the most part, the goal of treatment is to improve your quality of life by reducing the degree of leakage and providing you with a greater sense of control. Perfect urinary control, to the point that no accidents occur at all, is not attainable in many situations, and it would be too much to expect that your surgeon can guarantee this. Another point to understand is that, while these surgical approaches are fairly minor and safe, complications unfortunately can happen to some men. Finally, depending on the operation chosen, surgical revisions for various reasons may also be required over time. Significant urine leakage can obviously have a negative impact on one's overall quality of life. It can also affect sexual relationships. It can limit one's daily activities. And of course, it can slow down a patient's return to work following surgery. Your doctor and others in your community can help you to live with and manage incontinence, so don't be afraid to speak up if you are bothered by this problem. In summary, loss of urinary control, called incontinence, does occur in some men following prostate surgery. There are different types of incontinence outlined in this presentation. Successful treatments do exist for this condition, and your doctor can help to improve your situation. Thank you for viewing this educational program.